Good. Well, welcome back, everybody, and hope you're all now fully hydrated, but not over so. It's a real pleasure to introduce Lorna Marson as our first keynote speaker. Lorna, like me, is a trustee of Kidney Research UK and is a transplant surgeon in real life. And she's going to be talking about outcomes in transplantation. Lorna, over to you.
Thank you very much. I'd like to thank Kidney Research UK very much for the kind invitation to come and talk today about some of the work that we've been doing, really looking at how we can improve outcomes following renal transplantation. It is well known to this audience that kidney disease can affect anyone, irrespective of age, gender, or social status. And the management of patients with end-stage renal failure can involve dialysis, either hemodialysis or peritoneal dialysis, or kidney transplantation, which is transformational in terms of quality of life and also confers significant survival benefit. And this graph just shows that for each age group shown along the x-axis here, transplantation has a significant survival benefit when compared with dialysis, and trending towards that of the general population. But what is also well known to this audience is that there is a significant shortage of organs for transplantation. And this is a graph which anyone speaking about transplant has to show. It's compulsory. This is data from NHS Blood and Transplant, which shows, and this is for kidney transplant only, this is the kidney transplant waiting list compared with the number of deceased donors year on year and the number of kidney transplants. And although 2015-16 saw the highest number of deceased donors in the UK since the records began, you still see that there is a significant discrepancy between the number of patients waiting for a transplant and those receiving a transplant. And this has led us to increase the pool of donors which we would consider suitable for transplantation. And this graph just shows the year-on-year increase in the number of donors following circulatory death, shown on this graph in pale blue, which is now approaching the number of donors following brainstem death. And as has already been mentioned this morning, such donors, the kidneys from such donors are susceptible to more warm ischemia and therefore more damage. And interestingly, you can see that the number of living donor transplants being performed year on year remain relatively static. And there is a significant amount of work going on through NHS Blood and Transplant to try and increase the number of live donor transplants to be performed. We're also seeing a significant increase in the number of donors whose organs are used for transplant over the age of 60, as shown in the two shades of grey there. In addition to that, we're considering accepting kidneys from donors who have had significant past medical history of cardiac disease or hypertension. And all of these factors then do impact on the outcome following transplantation. And I'm going to focus on two areas that are really a significant clinical challenge to those of us working in transplantation. The first is ischemia reperfusion injury. Ischemia reperfusion injury occurs as an inevitable consequence of the process of removing a kidney from a donor in one part of the UK, transporting it across the UK, and transplanting it into the recipient. Clinically, it manifests itself as a delay in the commencement of function of the kidney, and it can occur in up to 50% of all deceased donor kidney transplants. Delayed graft function is associated with an increased risk of acute rejection, higher serum creatinine at 1 year, and an increased risk of graft loss. Risk factors for the development of delayed graft function include those donor factors that I've already shown you are increasingly common in our donor population. Older donor age, donation after circulatory death, and donors with significant comorbidities. Recipient factors do play a role, increasing age and diabetes, and also prolonged cold ischemia time. And that's something which I'm going to talk about in a moment. So, what strategies can we use to combat ischemic reperfusion injury? We can optimise that logistical process that I've described, from the removal of the kidney in one centre to its transplantation in another. As has already been alluded to, managing the donor to improve the outcome of the organs is an ethical minefield, and in general, both legislation and ethical considerations have steered us away from that within the UK. We can treat the organ itself through perfusion, as has already been described by the previous speaker, or by treating the kidney whilst it's out on the back table prior to transplantation, or we can treat the recipient. So one of the most significant factors that affects delayed graft function is prolonged cold ischemic time. And this is the time taken from removal of the kidney from the donor, placing it usually in static cold storage and transporting it to the time it comes out of ice during the recipient operation. And we have undertaken a national study which examines this logistical process. And I'm going to spend a little bit of time on this rather busy slide. So clearly, in terms of donor surgery, the cold ischemic time commences with in situ cold perfusion. A huge amount of work goes on in our histocompatibility and immunogenetics laboratories. First of all, to type the donor to ensure that we get the optimal match for that kidney. And secondly, to undertake what we call a cross-match test, where essentially tissue from the donor is mixed, if you like, with a blood sample from the recipient to ensure that there is either low or no reactivity between the donor and recipient cells. And until about 10 years ago, all patients undergoing kidney transplantation had to undergo a formal cross-match test prior to the transplant going ahead. And this cross-match test takes about 4 hours to undertake, so the cold ischemic time is increased automatically by that length of time. About 10 years ago, and it was led by the H&I laboratory here in Cambridge, the clinical scientists worked out that some patients are at very low risk of a positive cross-match. So patients who've never had a previous transplant, have not had previous pregnancies, or are at low risk of a positive cross-match. And so a virtual cross-match policy was adopted. And you will see why I have spent so much time explaining that when I show you the next slide. Clearly, the kidney needs to be transported. The recipient needs to be called in. And in our programme in Edinburgh, we cover the whole of the east of Scotland, including the Highlands and Islands. So our recipients really can have a very long way to travel. Patients may need haemodialysis prior to commencement of the transplant. And then we also try to examine how easy it is to access theatre, usually in the middle of the night. This work was undertaken by Susie Schresser, and I have rather embarrassingly narrowed her entire PhD down to one slide. But what we showed is that initially, importantly, there is significant variation in cold ischemic time between centres, between 10 hours in the shortest cold ischemic time centre and 20 hours in the longest. So clearly, this was work that needed to be done. We needed to find out why this was occurring, with a median cold ischemic time of just under 14 hours. The single most important factor that affected cold ischemic time in this study was the introduction of the virtual cross-match policy. And this led to a mean reduction in cold ischemic time nationally of 3 hours when compared with the prospective cross-match group. And this graph just shows the variation in practice between the 23 transplant centres in the UK. This shows the percentage of transplants that are performed using virtual cross-match shown in blue here, and those using prospective shown in red. And you can see huge variation in practice, and indeed 2 centres at that stage were still undertaking prospective cross-matches in all patients prior to transplantation. Those 2 centres have now adopted the virtual cross-match policy. Other factors that contributed to increased cold ischemic time were the technique that was used to undertake the prospective cross-match where required, if the recipient needed hemodialysis, and what was really depressing, challenging, interesting was that even when the patient, the cross-match, and the kidney were all ready, there was still a significant delay in getting access to theatre. And really, the timing of this is important because currently there are huge discussions around commissioning for renal transplantation in England and Wales and a transplant tariff. And so this data can then feed in to those sort of very important national discussions. So, as I've said, we can treat the kidney, if you like. And there are various techniques for perfusion. And I'm going to use as one example that of Mike Nicholson's group, which is, this work is being funded by Kidney Research UK. And the main purpose of his work is to reduce the kidney decline rates, which are due to inadequate perfusion. So the focus is slightly different, but nevertheless very relevant. And in their publication in the American Journal of Transplantation in July, they describe how they have successfully transplanted 2 kidneys that had been declined by all transplant centres across the UK using their technique of ex vivo normothermic perfusion. And using this technique, the kidneys, when they arrive at the transplant unit, are perfused with this warmed, oxygenated solution with nutrients for 60 minutes, and this allows some time for quality assessment, and an objective decision is made as to whether or not these kidneys are transplantable. And this clinical study clearly follows on the back of a number of years of work, particularly using pig models by Mike Nicholson and his group. And these are the kidneys, and I hope from where you're sitting, you can see, it's not, my laser pointer isn't working, oh yes, you can see that actually there is a discrepancy in the perfusion of this kidney. This is the left kidney. This is what we like to see, this pale colour of the kidney after perfusion on the back table. But you can see that just under half of that kidney has this patchy perfusion, and perhaps less clearly, but nevertheless you can see that on the right. This is the right and left kidney after it's been on the rig for an hour, and you can see the uniform perfusion. That looks like a healthy kidney, which if I transplanted, I would be happy if the kidney looked like that. So this is really exciting work, which Mike Nicholson, I think we'd have to call him the pin-up boy for this work. I hesitate before using that term, but he would be the first to admit that actually it's Sarah Hosgood that does all the work. He's not here, luckily, so I can say that. So an alternative strategy when it comes to treating the kidney is as I say, to treat the kidney on the back table. And this is work which was really instigated by Steve Sachs and others at Guy's, which is really based on the principle that it's the reperfusion of the kidney at the time of transplantation which induces this significant inflammatory response. And Steve Sachs is particularly interested in how this relates to complement activation. And his group published this work, it's on a rodent model of transplantation in 2006, which used a complement regulator and demonstrated improved survival in the treatment group compared to the control group, with improved renal function with a lower serum creatinine in the treatment group compared to the control group. And this work has now been translated into a multi-centre clinical trial, which is ongoing currently, called the EMPIRIKAL study, led by Martin Drage at Guy's, which tests the superiority of this complement regulator, myrocacept, in the prevention of ischemia reperfusion injury, compared with our standard technique of perfusing the kidney on the back table with a cold preservation solution. And the primary endpoint of this is delayed graft function. Our focus in Edinburgh has really been to how can we treat the recipient to minimise the impact of ischemia reperfusion injury. And this is work that I've undertaken with David Cluth and Jeremy Hughes, which focuses really on the protective enzyme hemoxygenase 1, which is expressed in macrophages and renal tissue, and it is the enzyme linked to the breakdown of free heme into iron, carbon monoxide and biliverdin, which is further broken down into bilirubin. And work, again funded by Kidney Research UK and undertaken by David Ferenbach, has demonstrated in a native ischemia reperfusion injury model significant protection of heme oxygenase 1 in the context of IRI, which is reduced if we deplete the macrophages in the rodent model of macrophage depletion, suggesting that it's macrophage expressing HO1 which confers protection in this model. We've undertaken some similar work using our renal transplant model, which again suggests that induction of heme oxygenase 1 with the drug hemarginate does confer protection, and indeed in human studies, higher graft HO1 expression was associated with better function. And this background, again, of experimental work led us to undertake a phase 2b clinical study, which we completed about 18 months ago, in which we administered hemarginate or placebo to 40 recipients of deceased donor renal transplants, with the primary aim of seeing whether we could induce heme oxygenase 1 in these patients. So the endpoint was not a clinical one in the sense of primary function, but it was really, does administration of hemarginate in these patients lead to upregulation of HO1? And we demonstrated in the peripheral blood mononucleus cells a significant upregulation of HO1 with hemarginate at protein and mRNA level. And in addition, we showed upregulation of heme oxygenase 1 in renal tissue in those patients that underwent a protocol biopsy. And this has led us to we're now seeking funding to undertake a multi-center study. We've had agreement from 14 of the transplant centres in the UK to recruit into this study, in which we will once again administer hemarginate to patients who are brought in for deceased donor transplant, with the primary endpoint at this stage of primary function or a reduction in rates of delayed graft function. So what I've tried to demonstrate in this part of the talk is that there is a lot of work, there's a lot of interest in ischemia reperfusion injury, and I think what is really exciting about this work is that we are seeing genuine translation of bench, basic science, laboratory-based research into now clinical trials. And the outcome that we're all looking for is this, which is primary function after reperfusion on the operating table. The second clinical challenge that I'm going to talk about is that of chronic allograft damage. And despite significant reductions in the rates of acute rejection with new and highly effective immunosuppressive agents, chronic allograft damage continues to cause the loss of about 5% of kidney transplants annually. It is characterized by interstitial fibrosis and tubular loss. It has a multifactorial etiology, and there are no treatments available to combat it. I just wanted to give you a brief aside here. When I decided in my wisdom to move from being a breast trainee to being a transplant trainee at quite a senior registrar level, I went to talk to Professor John Saville, who will be a familiar face to many of you, because I wanted to develop an academic profile in this. He gave me two pieces of advice. One was to speak to this slightly dodgy-looking character who's here on the front row, which took about half an hour and which has led to now probably more a decade, rather embarrassingly, of ongoing working and collaborating, which has been very fruitful. The second piece of advice was learn how to transplant kidneys in mice. Now, that sort of thing just rolls off the tongue easily, but this took me significantly longer than this did. And I wanted just to share a little bit of that pain with you. And this is what I'm talking about. So this is magnified at 25 times. So you can see here, this is the kidney, which we see was less than the size of a 1p piece. These are the vascular clamps, which are less than a centimetre across. And this is the aorta and cava on the mouse. And I don't know if you can see it here, but this is the venous anastomosis here, and this is the arterial anastomosis here, using a 10, I'm probably the only surgeon in the audience, so it's perhaps more detail than you need, but 10 or 11O suture, which, to be honest, is virtually invisible under the naked eye. But whilst it's been a painful process, there is no doubt that it was a very good piece of advice, and it's allowed us to develop models of transplant ischemia reperfusion injury, of acute rejection. If we transplant a C57 black 6 kidney into a BALB-C mouse, they develop acute rejection. But also, more importantly for me, a model of chronic allograft damage, if you like. The BM12 mouse has a single mutation on the MHC class 2 compared with the C57 black 6. And so if you transplant a BM12 kidney into a C57 black 6 mouse, you get changes more akin to chronic allograft damage rather than the florid acute rejection you see with a stronger mismatch. And what I really wanted to explore is some of the cellular contributors, if you like, to chronic allograft damage. All of the focus in transplant immunology up until about 6 or 7 years ago has been on T cells, and there has been more interest in recent years about other cells and their contribution. And we were interested in macrophages. There was evidence that graft macrophages are associated with worse outcome in various transplant models. There was some discussion around potential mechanisms of injury related to macrophage cytokine production. And we initially looked at macrophages in human transplant nephrectomy specimens. So these were transplants that had been removed because of chronic allograft damage. And we demonstrated significant graft macrophage infiltration and loss of the microvasculature and promotion of the lymphatic vasculature, if you like. We went on to use our experimental model to deplete the macrophages in this model of chronic allograft damage, and we demonstrated in that model a reduction in fibrosis with tubular preservation and preservation of the microvasculature. And this is work that was undertaken by Feng Kui and Anya Adair. I then went on to explore one of the possible mechanisms by which macrophages cause this damage in the model of chronic allograft damage. And for this, I collaborated with Tariq Sethi, who's a professor of respiratory medicine now at King's. And he had a particular interest in galectin-3, which is expressed in fibrotic disease of various etiologies. And mice deficient in galectin-3 have been shown to have reduced fibrosis. And so this was a potentially novel target for intervention. And this is what we did. We undertook the transplants in the allograft group just between the BM12 and C57 black 6. We had a syngeneic group, and we had the galectin-3 knockout group, in which BM12 kidneys were transplanted into the galectin-3 knockout, which were on a C57 black 6 background. And we demonstrated that there was significant tubular loss in the allograft group compared with the syngeneic, shown here in grey, and that was reduced when we knocked out in the galectin-3 knockout group, shown in black. When we looked at fibrosis, there was significant and intense fibrotic reaction, shown here with picrocereus red staining, in the allograft group, both at 4 and 8 weeks, which was reduced but not entirely abrogated in the galectin-3 knockout group. And this was also shown with a reduction in collagen-1 expression and alpha-smooth muscle actin expression in the galectin-3 knockout group. We were interested in the macrophages, as I've said already, and we were surprised initially to find that the number or percentage of F480 positive macrophages in the allograft and in the galectin-3 group were not significantly different. But what we did find is a change in expression of this marker YM1, which is a marker of the M2 phenotype, the pro-fibrotic macrophage phenotype. And we found that in the galectin-3 knockout group, there was a significant loss of YM1 expression compared with the allograft, suggesting that galectin-3 plays a role by promoting this transition or change in macrophage phenotype to a more pro-fibrotic phenotype. At the time of undertaking this work, there was no way of inhibiting galectin-3 in clinical studies, but Tariq has gone on to develop such an inhibitor, and so it'd be interesting to take this work forward. One of the things that caught our attention as we developed our model of chronic allograft damage was these B-cell-rich nodular aggregates that were seen in our chronic allograft damage model, which I think are highlighted most clearly on this low-power picture. And at this time, Oliver Thaunat and others had demonstrated similar nodules in similar nodular aggregates in clinical transplant tissue in chronic allograft damage. And so George Say joined me at that time to undertake his PhD and was very interested in this. And again, he was successful in being awarded a Kidney Research UK Clinical Training Fellowship. And at this stage, little work had been done in terms of B cells, and it was still quite unclear their role in both acute rejection and in chronic damage. And a recent publication by Mena Clapworthy and her colleagues in the New England Journal of Medicine had caught everyone's attention because they used the B-cell depleting antibody rituximab, anti-CD20, at the time of transplantation in a clinical trial, which had to be stopped early because those patients that were given rituximab at the time of transplantation had higher rates of acute rejection than those who were not given rituximab. And this really began to kicked off the discussion in the context of transplantation about the potential role of regulatory B cells, and perhaps B cell depletion is not always a good thing. And in addition to that, there was an increasing understanding that B cells are not just antibody-producing cells, they act as antigen-presenting cells and also act as cytokine-producing cells. So George undertook a piece of work examining the role of B cells in promoting chronic allograft damage using our model, and he depleted B cells at the time of transplantation and 4 weeks later. And for the purposes of this talk, I'm going to focus on the results of treatment at 4 weeks later, because interestingly, and probably in line with Mena's work, we found that when we depleted B cells at the time of transplant, there was no benefit to be gained. And this really just shows that we successfully depleted the B cells using the murine anti-CD20, which were not depleted when we used the human antibody rituximab. And this is just shown graphically here at 8 and 12 weeks. What we also found is that anti-CD20 treatment and abrogation of the B cells wiped out the GL7 expression, which pertaining to germinal centres within this model. B cell depletion at 4 weeks resulted in a loss of, in a preservation of tubules. No, sorry, this is the fibrosis, I apologise. So anti-CD20 treatment here demonstrated a significant reduction in fibrosis, interestingly at 12 weeks and not at 8 weeks. And similarly, there was tubular preservation in the treatment group compared with the controls at 12 weeks, but not at 8 weeks. So B-cell depletion at 4 weeks led to preservation of tubules and reduction in fibrosis later on during the injury process. What we also found, somewhat to our surprise, is that B-cell depletion also led to a significant reduction in the expression of CD3 positive T cells in this model. And you can see that here, both on immunohistochemistry and graphically. In addition, we saw a reduction in the number of macrophages and in other markers of fibrosis. George went on to examine one possible mechanism by which B cells clearly recruit the T cells to these kidneys following in chronic allograft damage by isolating the B cells from the kidneys at 4 weeks. And what he demonstrated is that there was significant expression by these B cells of these T cell chemokines and pro-inflammatory cytokines. And so, again, we await with interest the results of this study, which is being run again by Kings and Guys, in which rituximab is being administered to kidney transplant patients who have developed chronic antibody-mediated rejection. My concern about this study, if you like, is that by the time that diagnosis is made, then it's probably almost too late to reverse it. And this has really led us to our new horizon. Bear with me as we skip around again. which is, so Victoria Banwell has just joined me to undertake her PhD, and what we're really interested in now is how can we identify chronic allograft damage before it's too late. So up until now, the way that we diagnose it is by biopsy. We only subject our transplant patients to a transplant biopsy when their renal function is deteriorating. In the majority of centres, I think 1 or 2 centres still do protocol biopsies. And if we undertake these biopsies in response to a decline in renal function, then the damage is already done. And so we're wanting to undertake some work to see whether we can track the development of fibrosis following renal transplantation and then intervene early with rituximab or a galectin-3 inhibitor. And we are working in collaboration with Laura Denby, who's also funded by Kidney Research UK, because she's done a lot of work in other models of renal fibrosis on microRNA 214, and we are going to combine that with some interesting work that we've done with our clinical research imaging facility in Edinburgh, looking at the potential of using MR elastography to define early fibrosis in these transplant patients. So I think renal transplantation has come a long way since the first live donor transplant was performed in 1960, and I think our media coverage of such transplants has also improved. I think the recipient has a sporting chance of getting away with it. Obviously, I would like to acknowledge everyone who has done the work with me in the laboratory over the last decade or so. Spike and Gary, who are completely irreplaceable. Spike sadly just recently retired, who've worked with me on the animal side, various PhD students, and Jeremy and David, with whom I enjoy ongoing collaborations, and obviously the funders. But I would like to leave you with a slight health warning. So I was invited to become a trustee of Kidney Research UK. It's probably now about 5 years ago, and I think from my discussion with the then chair, I thought I would have to go to a few trustee meetings, I'd go to the AGM, I would hopefully contribute in some way in discussion to the research strategy. I hadn't quite understood what I was letting myself in for. For example, finding myself talking to about 300 women of Scotland over lunch, which was one of the most terrifying things I've ever had to do, particularly because I had to share the platform with Jacqueline Wilson, who's an amazing and prolific children's writer. I have really enjoyed and am always amused and humbled in equal measure by working with the peer educators who work with the Black and Asian minority ethnic communities in the west of Scotland, who are very entertaining. And this was then they were shortlisted for an award in NHS Scotland awards, team awards last year. And I still get my daily inspirational WhatsApp quote from one of these lovely ladies. And finally, and certainly not least, I was talked into, against my better judgment, by one of the senior management team undertaking the Ride 100 last year, which I did, but probably won't do again. Thank you very much for listening.
Well, thank you very much, Lorna, for an inspirational talk, which I'm sure is going to prompt lots of questions. But can I start off?
Yes.
When you deplete B cells in your models, are the B cells that come back the same as the ones you got rid of in the first place, or have they changed in some subtle way?
So, as far as we know, they are pretty similar. They do undoubtedly rebound back, not quite as much as the macrophages do. The macrophages are more concerning. They rebound back in a more pro-inflammatory and in increased numbers. The B cells don't have the same, have a rebound effect, but it is less aggressive, if you like, than the macrophages. But they do seem to be otherwise similar.
So does that go any way to explain the difference between the 8-week and the 12-week is what I was thinking about?
They remain deplete. Yeah, they remain deplete at 12 weeks. So I guess that's the advantage also for rituximab in the clinical scenario has an effect for about 6 months. So it's quite a long-term process. And similarly, the anti-CD20 antibody in the mouse seems to have quite a long-term effect.
So in terms of manipulating that as for new transplant therapies,
Yeah.
you've given us several pathways.
Yes, yes,
Which
yeah.
is your favourite?
I think I think the B cells are a sensible approach. I think because we have a safe and effective antibody treatment with rituximab, if we can get our timing right of intervening with rituximab, then I think that is sensible. And I also think that there is good evidence to show that actually there is often an antibody-mediated component of this chronic damage. So chronic antibody-mediated rejection, if you like, which is historically has been very difficult to diagnose and define, but probably contributes to chronic allograft damage commonly. But I like them all.
So it's a bit unfair to ask a keynote speaker to take questions, but if there are any questions,
It's fine.
Laura doesn't mind, I think.
No.
John?
Can I just ask, back in the 90s I was an SHO in haematology, and we wrote a paper about rituximab, recently invented, for a guy who had resistant B-cell lymphoma, and successfully treated it. But he then went on to develop a purely T-cell lymphoma.
Okay.
And I've always been worried about the balance between the T and the B cells in this environment. And I wonder if you had any thoughts about the sort of impact on that balance within this scenario by depleting in such a sort of important time frame, if you like.
I think that's why we were really interested to see that by depleting the B cells, we actually significantly depleted the T cell population. And we didn't entirely expect that, then I guess explained by the cytokine production profile of the B cells. So we would hope that such depletion would be protective. But again, I think alarm bells, I think we really have to dissect this out because of Mena's original work with early treatment with rituximab, which led to increased rates of acute rejection. Again, that's the concern.
It's really a follow-on from that about safety and any data we have in people whose T cells have been put half to sleep and you now take away their B cells. Certainly anecdotally, we've seen one or two catastrophic infections over the years. But they were usually people being very heavily immunosuppressed, but with that combination, I wondered if there was any safety data.
Yeah, I mean, we use, in terms of rituximab, we use rituximab routinely for our blood group incompatible transplant. So our patients are treated with rituximab a month before transplant, and clearly that has an ongoing impact. And we don't see an increased rate of T-cell mediated rejection. Certainly the national data doesn't suggest that they are more susceptible to see T-cell mediated rejection in that early time period. And rituximab is used, and I know there's a lot of discussion about how to optimally treat antibody mediated rejection, and a discussion about, and I think at the moment people do things slightly differently, but rituximab is part of the armamentarium, as is ATG. So infection is always a concern, and I suppose, but not specifically related to that. It's more around the burden of immunosuppression, as you're alluding to, and we would always want to strike that balance.
I don't know how good the sort of clinical factors are predicting chronic allograft rejection. Do you think that there would be a role for developing clinical predictive models for chronic allograft rejection and then treating a proportion of patients prophylactically, possibly with low-dose B-cell suppression?
So I think attempts have been made to try and define, and we know that if a patient has a delayed graft function, episodes of acute rejection, these all are cumulative and are more likely to lead to chronic allograft damage. The timing of it is really difficult to define, and so there have been attempts to try and define it clinically, but in a way that's why we're trying to identify those early markers to see whether actually by non-invasive markers could allow us to over longitudinally observe these patients prior to developing significant changes.
If you look at people with very good long-term graft function, is there any evidence their B-cell profile is different?
Ooh, that's a good question, isn't it? I don't have the answer to that. I think view would be that there is not evidence, but I wouldn't be able to be sure. I would have to double check that, which I will do now, of course, Professor Bishop.
It's another of the good outcomes of
Yeah,
meetings like this.
exactly. That's great.
Great. Well, thanks again,
Thanks
Lorna.
very much.